Okay, so we are picking up the discussion of the chromosomal disorders, especially the trisomies. And we're going to talk first about trisomy 21, which is Down syndrome. Most of you are probably familiar with it. It is the most common trisomy among live born infants. Although the rate of miscarriage is higher, there are a lot of people who are born alive with Down syndrome. It is not incompatible with life. It does affect males and females in all races equally. Incidence at this moment in time, about 1 in 800 births, according to your textbook. That statistic varies among sources, and over time it varies too as testing options become more available. And people sometimes choose to terminate pregnancies affected by Down syndrome. Most of these are caused by meiotic non-disjunction. So during meiosis, those two copies of chromosome 21 stick together and end up in a haploid cell, um, and then combine with another gamete to form a trisomy. There are many features. Some of them are pretty classic and shared by just about everybody, and some of them vary widely across the pool of individuals. And individuals do share the variations in skin, hair, and eye color with other family members. So, some of the classic features, let me see if I can do my pointer without skipping to the next slide. So, we have baby here. She is so stinking cute, but she does have some classic features. I'm going to point your attention to the flatter face and the upslanting of the palpebral fissures. Palpebral fissures are the openings to the eye. Um, there is decreased intellectual development. It used to be thought that that could range from like profound to moderate. And that's probably more common in the day when babies with this easily identifiable syndrome were institutionalized or otherwise deprived of intellectual stimulation. With special therapies, most of them end up in the milder to moderate range, although that can vary, and the potential is not predictable. Um, Congenital heart defects, especially your cardiac cushion defects, valve problems, um, atrial septal defects, ventricular septal defects. I have seen a baby with tetralogy of Fallot with Down syndrome, and that kind of varies with the individual sometimes, and even among the individual heart defects. An ASD could be really small, like a pinhole that causes no problems, or it could be really large and require repair. Um, Same thing with aortic stenosis or pulmonic stenosis. It just depends on how severe it is, how much function you have with your heart. But about 50% of babies, I think, was the estimate that I read for heart defects. Again, some of them are so mild they don't require anything special. Some of them might require surgical repair. And we have the Simeon Crease. So when you're assessing a baby, always open their little hands, count the fingers, make sure you don't have any extra, make sure they're not fused, and look for the Simeon Crease. And I'm probably going to say that a few times, hint, hint. So it's one flat line that goes across. And that line sometimes is only on one hand and it's not associated with Down syndrome. But if you see it on both hands, it's a marker. It's not diagnostic, but it does kind of point you in that direction. And then we have the epicanthic folds, those little folds here. And like I said, the upslanting of the palpebral fissures, the flatter face, the widely spaced eyes, and then low set ears. So this is another one when you are assessing a baby. A lot of babies, cartilage in the ear is kind of soft at birth. And sometimes those ears fold over because the head was molded in the birth canal. But the way you do it is you line up this inner canthus and you go straight across. And you can see that the juncture of the pinna, oh, not again. Hold on one sec. Okay, we're back. Sorry. That kind of happens with my touch screen sometimes is it advances to the next screen and then the screencastify won't let me go back because it blocks that little feature. So the inner canthus of the eye here goes straight across, and the pinna of the ear, the juncture of the pinna of the ear with the head is here. If you go straight across, you will note that it's not in line. The ears are set low. So always assess your baby very carefully. There's a lot of things to look at in a newborn. Um, let's go on. So some more health risks for Down syndrome. They usually are floppy babies with bad tone. Their reflexes are kind of meh, and they may be very poor feeders. So the reflex, like the suck reflex, the root reflex, all of those will be slower. And these babies get tired. Now, if they have a heart defect on top of it, they tend to be very poor feeders because it's exhausting for them to eat. Some of them will actually decompensate while they're feeding. You'll see them get floppier and sometimes gray or blue, or they might just stop feeding and not get enough nutrition. That poor muscle tone also extends to the muscles of the tongue and the mouth. So there's a tongue thrust usually. It can be very hard to get a good latch on these kids. You need a lactation consultant to help with the feeding if this mom is exclusively breastfeeding. And if they're bottle feeding, you need to be careful that that suck, swallow, breathe reflex is kind of coordinated. These babies are more likely to have vision and hearing losses at earlier age. So if you were involved with this family at the pediatric level, you know that they need more frequent screening and probably more specific. Now, there's a premature aging risk with Down syndrome. So there's cataract formation, things that you see in older people, you will see in younger folks with this syndrome. Higher risk for Alzheimer's. I think the rate is about 90% for people who live longer than age 40. There's an increased risk for leukemia. So they should have regular blood work, a CBC, complete blood count. Hypothyroidism, so that should be screened. Again, higher rates of cardiac defects ranging from a small VSD that they don't really repair to something like, coarctation or pulmonic stenosis or something serious that really impacts that baby's survival. And there are higher rates of intestinal obstruction, so parents will need to be taught about that. Now, one of the things that makes complicated to assess this baby is that they don't typically cry as much. They don't get worked up about things that other babies do. Um, so if they're in pain from an intestinal obstruction, it might be a little bit late in the game by the time you catch it. So parents need a lot of education with that. There is testing for Down syndrome now. Hint, hint. There was already a slide about testing for chromosomal disorders. There will be more slides for testing for disorders like trisomy 13 and 18. They're almost identical. So here goes nothing. Chorionic villus sampling, amniocentesis, non-invasive prenatal testing, also known as cell-free DNA. These are diagnostic. The chorionic villus sampling and amniocentesis are invasive. The NIPT testing is not invasive, but not as conclusive. Then we have the quad screen. First trimester screen is another one. It's not on here, but I'll fix that. And some ultrasound findings that are consistent with Down syndrome if mom has declined testing through the pregnancy. Um, Somewhere in that second trimester, you'll usually see, sorry about the spelling error, I will fix that as well, thickened nuchal translucency, shortened femur length. There are other markers, choroid plexus cysts, echogenic bowel, echogenic cardiac focus. But there's a number. I think there are like 13 markers. Some of them are more indicative of Downs than others. But if you see a lot of them, definitely that person should be referred for more conclusive testing if they want that. Finally, you do a karyotype on the newborn through a heel stick. It's a blood sample similar to the newborn screen. And they can do a karyotype. You would request one maybe if you saw clinical features that were consistent with the disorder, or if mom had had testing that indicated a high risk. Usually a pediatric provider will order it. Some resources and support for Down syndrome. So early intervention services usually administered at the local level, at the county. Later on, they will be administered through the school system. We want to get this family hooked up right away. with these services. Children's hospitals that have centers for genetic disorders. The ARC. The ARC is a great organization. The acronym ARC used to stand for Association for Retarded Citizens, but as that word became more of a slur, and the new diagnosis category was intellectual disability, they kept the name the ARC and sort of, just made it known that they are no longer called that. It's no longer an acronym for that. There's the National Down Syndrome Society, National Down Syndrome Congress. There are Facebook pages. There are lots of places that you can refer families that are dealing with Down syndrome to. A lot of them are more locally administered, but there are services and support for these folks. They're probably going to need help with feeding. They will need referrals to different specialists. It could be a cardiologist. It could be a cardiac surgeon. It could be a vision specialist. They may need physical therapy, occupational therapy. They may need help with feeding. So a lactation consultant or feeding therapist could be important for them. All right. And we are going to cut that video off and pick up with trisomy 18 in just a moment.